Now we will read about the annular pancreas. It's a rare congenital anomaly in which the pancreas take a shape of ring around the duodenum. This is duodenum, and this is the ring of pancreas, which is formed by the ventral pancreatic bud. For the detail of this, the etiology, we have to go for the development of pancreas, in which at the 5th week of intrauterine life, the development of pancreas start, in which suppose this is the anti-abdominal wall, this is umbilicus, and this is our gut tube. This is foregut. Up to here is the foregut, then midgut and hindgut. At the junction of foregut and the midgut, on the ventral aspect, a small bilobed ventral bud arises. Bilobed ventral bud, just distal to the primitive bile duct. This is the primitive bile duct, and this is the bilobed ventral pancreatic bud on the anterior aspect. This is anti-abdominal wall, this is umbilicus, and just cephalic to the junction of foregut and midgut, a little bit cephalic, the large dorsal pancreatic bud arises. This is the large dorsal pancreatic bud, and this is the ventral pancreatic bud. Now, afterward, the right side rotation of midgut occur at the angle of 90 degree, due to which the ventrally facing or anteriorly facing this ventral pancreatic bud go towards the right side. This is our bilobed ventral pancreatic bud. This bilobed pancreatic bud later it fuses into one, and just opposite to that, here on the left side, this is the dorsal pancreatic bud, but a little cephalic position, and this is at the junction, just distal to the primitive bile duct. This is our ventral and dorsal pancreatic bud. This is right side and this is left side. Here it is anterior and this is posterior. Okay, and this is our gut loop, C-shaped gut loop, and here the rotation of 90 degree towards right side occur. Now what happens? There is differential growth of the duodenum, and this ventral pancreatic bud dorsal remain in its position, and now ventral, due to the differential growth, ventral come to the left side. This is right side, left side. The dorsal pancreatic bud is towards the left side, but here is the differential growth occur, which pushes the ventral pancreatic bud towards the dorsal bud by making an angle of 180 degree. This is what? 180 degree from the posterior aspect, not from the anterior, from the posterior aspect. Now what is the position? This is the loop. The C-shaped loop is facing. This is the right side and this is left side. Here is the rotation of gut occur, but here is the differential growth, which pushes the ventral bud towards the dorsal bud. This is dorsal bud, and now ventral bud in its lower part. It come here by making an angle of 180 degree from the posterior aspect. This is the normal development. But in annular pancreas, what happened? these bilobed ventral bud do not fuse. It remains separate, and one bud take the course from the posterior aspect, making angle of 180 degree, and one bud comes from the anterior aspect, and it surrounds the duodenum like a ring, and which will result into the annular pancreas. Okay, this is the etiology behind it. And what is the fate of this dorsal pancreatic bud? This will give rise to whole of the pancreas except the lower part of the head of pancreas and the acinate process. Okay, if we this is anti-abdominal wall. Suppose this is the anti-abdominal wall, this is the loop, here is the pancreas remain. Okay, and this is the dorsal, and this below that, this is the ventral bud. Okay, and this is the dorsal bud. The lower part of the head of the pancreas is formed by the ventral pancreatic bud as well as the uncinate process, whereas the rest is formed by the dorsal pancreatic bud. And just proximal to that, here is the our bile duct. Okay, this is the whole development. And the pancreatic duct, the dorsal pancreatic duct, here lies in the middle, there is dorsal pancreatic duct, and in the ventral bud lies the ventral pancreatic duct. Now there is an oblique communication. This is the ventral pancreatic duct and this is dorsal one. Now an oblique communication occur in between these two. And our adult form of pancreatic duct is formed by the distal part of the pancreatic duct of dorsal pancreatic bud plus oblique anastomotic shunt, oblique anastomotic duct, and then proximal part of the pancreatic duct of the ventral pancreatic bud. This is our major pancreatic duct, which is also known as duct of Wilson. And this will get degenerate, and this much part it gets separate from here, and this will lead to the minor pancreatic duct or duct of Santorini, which opens via the minor duodenal papilla, and this is the major duodenal papilla. It lies 10 cm from the pylorus, and this is 2 cm proximal to it. Okay, so this is the whole development and the etiology behind annular pancreas disease. Now come to the clinicals and the sign and symptom of annular pancreas. It is, अगर गट को हम लोग यहाँ से ड्यूडनल एट्रेसिया अगर यहाँ बांध देते हैं तो क्या हो सकता है, जितना खाना खाया वही रिगर्जिटेट हो जाएगा, तो बच्चों में क्या होगा, स्पिटिंग आउट ऑफ मिल्क होगा। अब बड़ों तो इसको हम एज ए होल लिख सकते हैं, नोजिया, वोमिटिंग, ब्लोटिंग। फिर ज़्यादा अगर यहाँ जमा हो जाएगा तो एब्डोमिनल पेन, और फिर यहाँ पे बाइल डक्ट भी ओपन हो रहा था, यहाँ पे इस तरह से स्ट्रैंगुलेशन हो जाएगा, तो बाइल डक्ट और पैनक्रियाटिक डक्ट सारा ही कुछ ओपन हो रहा है, तो ये रेट्रोग्रेड, ड्यू टू द retrograde flow of the pancreatic juice as well as the bile, this will lead to pancreatitis. Okay, the pancreas में यहाँ तो pancreatitis हो जाएगा, तो it will also lead to pancreatitis as well as which will lead to the abdominal pain. फिर abdominal perforation होने का डर रहेगा, फिर by the time it will lead to the pancreatic cancer, duodenal cancer. Okay, and what is the incidence of annular pancreas? It is 1 in 12,000 to 1 in 15,000 live birth. Okay, and there is association with medic, that is malrotation of midgut, esophageal atresia, Down syndrome, imperforate anus, congenital heart disease, ठीक है। और सब में ए अगर लगा दे तो बात बन जाए, मेडिकल हो जाएगा, इसमें पहल हो जाएगा और पीएच भी है, तो पीएच से क्या हो जाएगा, इसके साथ और किस किस चीज़ का एसोसिएशन है, दिस इज हाइड्रेमनियास, तो पॉलीहाइड्रेमनियास के साथ भी एसोसिएशन है, पेरिटोनाइटिस के साथ एसोसिएशन है। सब में अगर अल लगा देते हैं तो सारा ही कुछ पूरा हो जा रहा है। और फिर ये कॉम्प्लिकेशन क्या करता है, कॉम्प्लिकेशन ऑफ एनुलर पैनक्रियास, तो कप में जल के बराबर है, कप में जल, इसमें भी एल लगाए हैं हम, नहीं तो COPJ है, ओके। तो क्या कॉम्प्लिकेशन हो सकता है, ड्यूरनल कैंसर हो सकता है, पेप्टिक अल्सर हो सकता है, तो क्या क्या हो जाएगा कप में जल, दिस इज नॉट ड्यूरनल कैंसर, दिस इज पैनक्रियाटिक कैंसर, U for ulcer, that is peptic ulcer, and this is perforation। बहुत देर कहीं पे अगर रिंग बांध के रखा जाए तो वहाँ नेक्रोसिस हो जाएगा, फिर परफोरेशन हो जाएगा, परफोरेशन, ऑब्स्ट्रक्टिव जॉन्डिस, और ये तो वैसे ही लगा दिए हैं ताकि कप में जल के बराबर हो जाए। ये पहल करना चाहिए हम लोग का हर चीज़ का, मेडिकल, ठीक है। और हम लोग कप में जल पीने का पहल करना चाहिए, कप में ही लेके पी लेना चाहिए, कप में धोने में आसानी रहता है, ठीक है। अब हो गया कि इन्वेस्टिगेशन के लिए क्या करते हैं, तो इन्वेस्टिगेशन के लिए अल्ट्रासोनोग्राफी, एब्डोमिनल अल्ट्रासोनोग्राफी करेंगे, एब्डोमिनल एक्सरे करेंगे, तो इसमें पता चल जाता है, ठीक है, एनुलर पैनक्रियास का। और इसका ट्रीटमेंट में क्या होगा, सर्जिकल ट्रीटमेंट है, जहाँ पे ऑब्स्ट्रक्शन हुआ उससे पहले और पीछे सर्जिकल कम्युनिकेशन टू बाईपास द ड्यूरनल ऑब्स्ट्रक्शन, जहाँ पे ऑब्स्ट्रक्शन हुआ उसको छोड़ के उससे ऊपर उसके नीचे ज्वाइन कर देना है, ठीक है। तो दिस इज द ट्रीटमेंट।